Morning. Can you hear me?
Yep.
All right. Nice.
You, Erica. Yeah, Melissa.
Good morning.
So, Seth, I have your slides. Yeah, Melissa, I don't remember whether you sent them back or if you want to share from your...
Either way, they're staying the same. So whichever way is more comfortable. I printed them out for myself just in case.
Okay. Yeah. Do them if you... Yeah, Melissa, if you want to pull them up for yourself just in case. Is she still there? Yes, she is. Okay. Got a little person.
Morning from working at home.
All right. I'm just saying about it.
Are we doing the cases first? Or you said to pull up the slides now?
Yeah, one case first, then you, then the second case.
Okay.
Seth's going first. But we'll give it a couple more minutes, and then Seth will just do a round of intros, and then you'll be up. Okay.
Sounds good.
Yeah. Yes.
Hello.
Hey, Paige.
Wait, it's Gail. Sure.
Oh, hi, Gail. Also, I just looked up and saw a great big beautiful page in blue.
What's that?
So, hello everyone, and welcome to today's Echo Clinic. Before getting started with introductions, we would like to share a general reminder to maintain confidentiality by not releasing any personal health information of the individuals being discussed. Also, please send your name in the way you would like it to appear on your certificate and email address in the chat box below by the middle of your screen. Mute yourself when not speaking by clicking on the microphone icon in the bottom left corner of your screen. Audio participants dial *6 to mute and *6 to unmute. Prior to speaking during this clinic, introduce yourself by saying your name and location. This allows those who are using audio to follow conversation as they cannot see who is speaking. We'll start with introductions. Erica.
Oh, you're muted. Got it.
It's very early. Erica Pinella from Lehigh County Drug and Alcohol. I am their CRS.
Yamalisa.
Hi, good morning, everyone. This is Yamalisa Taveras, PACMAT team, as well as representative from Counseling Solutions.
Welcome. Seth.
Good morning. My name is Seth Campbell. I'm a physician assistant with Lehigh Valley Health Network Street Medicine, and I'll be presenting a case today.
Yay. Welcome.
Thank you.
Jillian.
Good morning, everyone. I'm Jillian Beecham. I'm the Department of Emergency and Hospital Medicine and PACMAT faculty and a recovery community ally. Good morning.
Great to have you as always. And I think we get you for an hour. Is that right?
That's right. Sorry to have to leave. I will be very sad about that.
Sigh. I'm sorry, I don't recognize your face yet, C7789. Yep, that's you.
That's me. Jill McCambridge. I am CCT Behavioral Health Clinical Coordinator.
Great. Hi, Bill. Can you introduce yourself? Great to have you here, too.
Good morning, Bill Rowan, Program Director, Lehigh Valley Hospital Schuylkill Counseling Center.
I love how that rolls off your tongue now.
I've had a lot of practice over the years.
Sophia.
Good morning, everyone. Sophia Harbove, PACMAT, BHI caseworker. Happy to be here. Good morning, everyone.
Wonderful to see your face this morning. Hi, Kevin.
Hi, good morning, everyone. Kevin McNeil, family doc, part of the PACMAT team.
Wonderful. Paige, in blue.
Morning, everybody. I'm Paige. I'm Program Coordinator for Addiction Recovery Services at Lehigh Valley Health Network and part of the PACMAT team.
Always a pleasure. Heather.
Hi, I'm Heather Cromer, CCT Behavior Specialist.
Thanks for joining us, Heather. Hi, Gina.
Hi, Abby. Good morning, everyone. It's Gina Hills, Program Coordinator for the Center of Excellence at Neighborhood Health Centers.
Bright and early. Jessica.
I'm Jessica Morris. I'm one of the community care team behavioral health staff.
Thanks for coming and joining us today. Franklin, I think that's you at C3904.
Good morning, Frank Ortiz. I'm the Behavioral Health Clinical Coordinator for the 17th Street Community Practices at the official Valley Health Partners. Nice to be here.
Awesome. Yeah, Lisa, we already did. Mackenzie, hi.
Good morning. I'm Mackenzie. I'm one of the family medicine residents over at NHCLV.
Thanks for joining us. Angie.
Hi, everyone. I'm Angie Callistra. I am Addictions and Behavioral Integration lead for the PACMAT and faculty in family medicine. Great to be here.
Great to have you. Jessica number 2, Jessica Deemer.
Hi, I'm Jessica Deemer. I'm in the Research Scholar Program, and I'm doing research with Dr. Callistra on addiction and stigma in family medicine.
Wonderful topics. Great to have you. Lauren.
Hi, I'm also a research scholar working with Dr. Callistra on her behavioral and addiction integration projects, and so excited to be here.
Great to have you. Judy.
Hi, I'm Judy. I'm a nurse care manager at 17th Street for the community practices with Valley Health Partners.
Welcome. And Judy, if you have video, we'd love to gaze upon your face. Part of the joy of having the video on Zoom is that we do get to know each other a little bit as a community. So even if we did see you for a second, we'd love to.
Okay, I'm actually in a simultaneous meeting with the practice also, so I'm just trying to go back and forth between the meetings.
Okay, wonderful. Gail.
Hey there. I'm Gail Stern, and I'm the administrator of psychiatry and an old psych nurse.
Young and hard though, Gail. Tom.
Hi, Tom Michaels, manager for social work and behavioral health. And I will put my video on in just about 30 seconds when I'm done with breakfast.
Tommy. You're on mute. Tommy, are you there? Tommy is somewhere nearby. So Tommy, we'll try and give you a chance to introduce yourself a little bit later. But what a wonderful group to have here today.
Abby, sorry about that. Computer troubles. I'm here. Hi, everyone.
And tell us about yourself, Tommy.
Hi, everyone. I'm the behavioral health specialist. I am embedded at the Family Health Center in Allentown. When I joined the team just about 2 years ago, I came on with the community care team with Pop Health, and now I've recently transitioned to Valley Health Partners Population Health.
Fabulous. Okay, welcome. Welcome, everybody. Really wonderful group to have here today. We're going to start with a case from Seth and our street medicine team. Very exciting. Can you guys see my screen?
Yes, we can.
Okay, so Seth, I'm going to sort of scroll through here and you tell me when you want me to advance a slide, okay?
Sounds great. Go ahead.
And you tell the story however you want to, but we've got these here for you as promised.
Absolutely. So one of the big, questions for today's meeting is really what's the best practice for warm handoffs for a patient who's experiencing homelessness, who needs MAT care. As far as the gentleman we'll be discussing, we had met him via an inpatient consult during an admission at Cedar Crest Hospital back in April of this year. At that time, he had obviously a significant past medical history of opioid use disorder that was considered to be severe. And at that time, he had suffered an injury resulting in osteomyelitis and the amputation of his right great toe. At that time during the consult, our program director, Nadia Quadrado, saw the patient and determined that he would qualify for our medical respite program, which is, if you haven't heard, we were able to secure a grant through Highmark in order to provide short-term recuperative care for anybody that's not sick enough to stay in the hospital, but not healthy enough for the streets. At that time, the gentleman really wanted to get in the halfway house, but apparently there was some issue with him being started on Suboxone during his admission, and not being able to enter some of the halfway homes. So at that time, it was determined that, you know, we would offer up the medical respite program.
And then recruitment, as far as the seat at the CMO, they finalized some 4 candidates.
Say again? Hello?
I think it sounded like someone was just off mute for a second, but I think you're okay, Seth.
All right, very good. And, you know, ultimately, I'm sure there's more on the next couple of slides here, but very, very goal-oriented. And just to give you a little bit of his history, I mean, as far as getting to know him, it was a little bit limited because I didn't want to pry. Anytime we see patients through the street medicine program, obviously, if they want to divulge into their history, we certainly lend an ear, but we really don't pry. So from getting to know him for the first encounter upon entering the medical respite program, it is housed at Extended Stay America off the Shonersville Road. 3 meals a day are provided by Meals on Wheels. We see them medically and allow them to kind of just hang out and recuperate. Laundry service is also provided, and again, trying to connect them with care for when they are released from the medical respite program. But his primary support was his family. Unfortunately, during his stay in respite, his mother passed, and you know, he had ultimately described his childhood as good. His mother was a major support system for him. So with the passing of his mom during his medical respite stay, it certainly worsened some underlying depression. However, we visit him quite frequently, and otherwise, the history of homelessness kind of remains unclear. Looking back to the chart, it's certainly years that it's been happening, but as far as rough sleeping on the streets, he was outside for a couple months prior to us meeting him in April, and again, we were able to accept him into the respite program upon encountering him for the first time in April during that consult. Regarding his history, you can see comorbidities on the PowerPoint slide there. At that time, he was not taking any medication specifically for depression and anxiety. Oxygen helped with sleep. He did not require the Narcan throughout his stay with us, but he certainly had it on hand just in case. And he had Suboxone during that time since being out of the hospital prior to what was the plan to transition him into NHCLV for continued MAT. Currently, within the street medicine program, we don't have a provider that does MAT. We aren't kind of set up, we're not ex-flavored. I've completed the training, but then we don't have any kind of policy and procedure set up right now within the program to be able to manage that and appropriately do that, but hopefully soon. As you can see, he certainly met the DSM criteria for severe opioid use, and ultimately with the Suboxone, he was able to obviously go into remission during his hospitalization and continue that upon release. You can see his past of mental illness, specifically depression, with anxiety as well. Multiple ER visits throughout the past couple of years. I think as far as the 7 ED visits, that's over the past, I want to say 3 years, and 3 of which resulted in inpatient admissions. He's been to rehab once. During his medical respite stay, we were able to get him into our telepsychiatry for 1 visit. So we also, it's a pilot program through street medicine in order to provide a behavioral specialist via an iPad and bring the behavioral specialist to the patient. and he was able to complete that to do a psychosocial to help with ultimately his care. And as far as continuing at Suboxone, you know, he wanted to get back on his feet. He expressed multiple times that he wished to, you know, give back and help others in need, including to the point of coming out with our program on street rounds to see folks that are rusted down the streets and try to provide some support. Also, upon release of from the medical rescue program, he did return to staying with his niece, which was his only support system at that time. And from there, we continued to have conversations with NHCLV, Dr. Lester and I, and staff, and Paige, and everybody kind of came together to, you know, wrap around this gentleman in order to transition care and have more of a warm handoff. Again, you can see his diagnosis. He's there. You know, certainly could have run further. Certainly complex history. But as you can see again, he really just wanted to get back on his feet, able to volunteer and stay housed with family. And as you can see, the plan was to continue MAT with us not having that ability. We reached out to NHCLV to continue the care, and I do believe he made it to his follow-up appointment last week, or establishment appointment last week, and Suboxone was continued. Tried to give him a call yesterday to chat him up about it, but he was not home. He also has no phone, but has been using his niece's number, and anytime you call, he just asks for the gentleman, and his niece hands over the phone.
Great. Thanks, Seth. So what we do next is we try and encapsulate this in one sentence, and then we'll open it up to the group for some clarifying questions. And those clarifying questions, as you all remember, are what do you want to know about this person so that you can start thinking about recommendations? We'll hold off on recommendations till the next round after that. But we have a young gentleman here with severe opiate use disorder and a mental health history with lots of ED admissions for his mental health, who was admitted for osteomyelitis and a subsequent amputation of his right toe. Street medicine was consulted due to his homelessness, and you guys did a lot to pull together a lot of services for him and create a discharge plan that would allow him to succeed in his recovery, which included med talks to do an inpatient induction for Suboxone, and then respite care and telepsych. And that was a lot of work. So we're looking at what are the best ways to have this guy then succeed in his primary care at NHCLV when he's sometimes hard to reach. Is that about get it?
Absolutely. And, you know, ultimately I do enjoy, you know, texting you, or texting Abby, but if there's a different way of, you know, getting in touch with people and having a streamlined process for anybody who's necessarily homeless, you know, I guess that's the question here.
Right. So clarifying questions for people. Jump right in from our community here.
I have a question. Hi, it's Gina from NHCLV. My question is, does this man have income?
Yes, he does. He receives Social Security disability.
Okay, thank you.
More questions?
Going back to the beginning of the presentation, did I understand he was interested, or at least possibly to be admitted to a halfway house, but it was a condition that he be on medication-assisted therapy for admission?
So it's my understanding through the note, because I didn't see him as the consultant, but apparently it was almost more of a barrier, because in the halfway house they didn't want anybody to have any form of narcotic in the halfway house, just for the nature of it.
Okay.
Hi, it's Gloria from NHCLV. I just wanted to add another question based on the gentleman who just asked a question. So you say narcotic, you're just talking about the MAT, but any form, because I know sometimes mental health prescribes benzos. Is that also something that they would not consider? I mean, we don't want to do benzos, but I don't know what his medications that he's on. I got on a little late.
So regarding the halfway house, I can't speak to their policies, but some shelters, some places, I guess restrict what medications enter the doors. I don't know if benzos would qualify for that. I don't think that poses as much of a problem, if you will, that I've experienced with getting folks into shelter or halfway houses or this and that. But for other folks within shelter, some places just are not comfortable with having any pill form of any scheduled substance in their facility. But I don't know exactly what that looks like in their policy and procedures.
I could just add that majority of facilities, even treatment centers, do not want to accept patients who are on benzos. And if they are, they'll do a quick wean, which is usually a bad idea. So we try to encourage people to avoid prescribing benzos, especially to patients with substance use disorders.
Thanks, Paige. Other question?
I can jump in with one. Seth,
Yeah,
do you have a sense that like how the patient would view himself within the community? And the reason I ask is just to think around what kind of other supports, how would he respond to a peer support? How would he respond to a recovery support group of some kind? Like, does he see himself as sort of being welcome into those kind of relationships, do you think?
I think since, almost turning over a new leaf here, that he might be more welcome, or might feel more welcome. I believe in the past when he had been a part of groups, specifically during his one inpatient rehabilitation admission, he felt as though he didn't want to share in front of groups, and groups almost had its own stigma, and wasn't necessarily comfortable. Now with his his internal motivation and being goal oriented to set a role model or an example for his nieces' children, I can imagine him being more open to it. And as far as I could see him finding a new identity and helping others and being a part of those groups.
Thank you.
Erica, I don't totally want to put you on the spot, but I would love to hear if you have any questions from the point of view of the CRS, since you're such a strong resource in our community. What would a CRS want to know about this guy?
I mean, I would want to talk to him around,
like Seth was talking about, what does that motivation look like, other than, moving forward in all aspects of his life, because it's not about just, stopping the substances. It's about changing that, that's how we live, so what does it look like without using? What are his next steps? Where would he want to go? It's really opening up those questions to change that mindset, as much as, and just kind of following his lead and assisting him from there. Like that's usually how I approach people in the community. And that's really how, when outreach was going out, that's how they also approach individuals that are in the community. Like where do they want to go? Because it's really meeting that resistance, and then finding out what that resistance, where that comes from. So that is my thought process. I know that I would have zero issue with helping you in connecting him with recovery support.
Seth, do any of those questions bring up anything else about this guy that you think you might want to share? Or what are his next steps for his life? You mentioned getting back and so on.
And for this gentleman, the toe amputation was, and I quote, "This was a wake-up call."
Mm-hmm.
I can't believe I had to lose my toe to really, see the light, if you will. So it's, as far as the stages of change, kind of early on, but definitely, has some energy going in the right direction. And, as far as, the motivational interviewing of, what does it look like, and, the open-ended questions, and, if you really quit drinking and using, how would you like to be different?
Mm-hmm.
That kind of questioning. I didn't dive in too far during our visits at the medical respite when I saw him, just because, my first visit with him was just pretty open-ended, and, going over what medical respite was, make sure he was successful there, which he was. He was actually our first gentleman that had a recent history of opioid use that we accepted into our medical respite program, and with being on the Suboxone, we just said, let's go for it, no biggie, and he obviously did great. And then a couple follow-up visits, and his mother passed, so it was a lot more just listening and not digging into him, just because knowing I was going to be his provider forever, with him being released from the program and establishing care somewhere else. Obviously I still call him up and chat him up, but to see how he's doing. But when he does start to see what his future could be, almost every time that we got even close to that, he did become rather tearful, and just kind of almost like it was just the first time he ever thought that way. So it's gonna take some time.
I have a not so much a question necessarily, Seth, as sort of a statement or an observation. One of the first things that you said really struck me. You said, "We lend an ear, we lend an ear, but we don't pry." And I'm like really struck with it. Well, I thought that was kind of a beautiful statement, and I really kind of struck with the tension between, we're just here to, we're here to listen, we're here to help in the way that makes sense for you, we're respecting your privacy. Then I also think about sort of the processes that are in place when it comes to substance use disorder, and how we have a certain list of criteria of questions that we absolutely need to ask. So there's a real tension there. I'm just interested in your thoughts about that.
Yeah, and I recently read the book The Deepest Well. It's by Dr. Burke, named Burke, who's big time in ACEs and this and that. So I highly recommend it. But in it, there was a short passage about, therapy and how providers, can kind of do that. And we might be the first, although, if I'm a PA, your doctor, we might be the first person that they trust in that sense that can open up, and we can provide a certain sense of therapeutic intervention and form a therapeutic alliance, if you will. But doing that with a gentleman like this, it's not, it's better to, kindly knock on the door or maybe ring the doorbell rather than, bust it open.
I just want to add, while this gentleman was a guest here at Cedar Crest for quite a while, and Holly Maddox, our CRS, went and visited him multiple times. And, she would come back and we would discuss, and he did open up to her and talk to her about the death of his mother and other things that were going on. And they developed quite a little, rapport. And and we tried really hard to get him into inpatient treatment because that's what he was really requesting. And I think it was kind of God working in his life. I think the route that he went and getting into the respite care, and I was really excited when Seth called and said that, that's where he was going, and he was going to be the first patient on Suboxone there. And I just think really this is the best, the whole scenario is the best, it's going to give him the best possible outcome. I think it was really excited to learn about the respite care. And I don't know, I think the whole team did a great job. I hope we can really continue to do this kind of care for these folks. Seth, you're amazing.
Well, I'm sorry, my history isn't very thorough, and as far as Dr. Miller goes, it's simply because I didn't have the time to dive into things, and I didn't really do the whole crowbar thing, but I just try to stay present with whatever is happening in our patients' lives, and stay present when I'm in front of them, and whatever happens during the visit, half hour, whenever we're there, that's cool. I'll be back, and that's kind of how we roll. But if a patient's focused on one thing and I'm trying to have them drink a different Kool-Aid, it's just how that works out.
I have a question.
Mm-hmm.
Can you hear me? Great. So one of your questions was about the warm handoff and making that a smoother process. Can you tell me a little bit about what would be ideal? Like, what does an ideal warm handoff look like for a street medicine patient? And if a miracle happened tomorrow, what would that look like?
I love talking about miracles. And I guess the miracle would be actually whichever staff member within the team knows the patient the best. That probably would have been myself or Patrick, our administrative coordinator, who also does the respite coordination, to actually, because we can't transfer patient, like actually physically take the bus or the taxi or whatever we have from the medical respite or wherever they're at to the doctor's office, sit with them in the waiting room, go to their appointment together, be right beside them throughout the whole encounter, and then take the bus or taxi back to, the respite program or camp, wherever they say. And, it's really almost just the physical presence of being there and not only going to them wherever they reside, but also going to their appointment with them. Because, not only, I guess in the history of street medicine, it's all just kind of been going off because of coattails of trust. And if I show up with a patient who knows me real well and I vouch for you, and that trust is just transferred into your coat pocket, and the care continues that way. So the as far as the warm handoff, that's how it would go on the front end of that, I guess, if you will. The communication, I don't know if it's I think it's more of a staffing issue within us to delegate that task to one of our full-time staff to get this gentleman to specific doctor's office. So when it came to this gentleman, I just called Abby, and we went from there. But if that's okay with everybody, I'll continue to do that. But I don't know if there's any other I don't know if anybody from the CCT team could chime in on a better process. I'm terrible at my inbox and Epic, so I don't want to go ahead and say like a referral should go in. But those kind of things, that's a new question. I'm not even sure what the back front end process would look like.
Thanks. And I just have one other question. Based on your chatting it up with him, do you know if there's been a period in his life when things have been going well? And what could you tell me about that time?
Well, I can tell you since 2016, there's been quite the struggle. I haven't, other than his childhood, he said that, he considered it to be good, especially with his mother, who was rather supportive, which I was surprised to hear regarding ACEs and everything, that I've been reading on that, but he described it as good. But from talking to him since release from the medical, from the respite program, he sounds great. And since the beginning, or since January to April of this year, he visited the emergency department 9 times. And since release from respite after his April admission, he hasn't been back. So it seems to be that he's, doing well health-wise. And when I chat him up on the phone, he seems to be doing quite well now.
Thank you. That's all for me.
Lisa or Jillian, anything that you guys want to add?
My question was if there are other supports. I know you mentioned like his mom passed, and that was someone that he had, but other than that, like any other supports that he has built through the last couple of months that he's been going through this process?
We stay in touch with him a little bit here and there, but as far as supports, his niece, I'm sure he's got some friends in the area. Whether or not they're good influences or not, I don't know. But as far as the support, that's all that I know that he's connected with is his niece. I don't know that he's connected with, any kind of like NAAA, peer support group, anything like that.
Thank you.
My question then will switch over to recommendations. Can you tell us a little bit about his decision to start the buprenorphine, and what those conversations were like, and what his motivation for that was?
So from what he shared, he almost wanted to go cold turkey, which, I recommend against, at least until he was with a stable outpatient provider. He didn't want to replace one thing with another, but, he seemed to tolerate it well, so he continued it. That was kind of his underlying view starting the Suboxone, but it was his first time giving it a go in an environment when he, had the wherewithal and the thought process to say, this is a wake-up call. I got to change. So that's, I think ultimately the the loss of his toe was the wake-up call that made him think, I got to do something. And if it is, you know, doing the Suboxone, let's do it, because I can't go back to the heroin. But ultimately, I from the conversations we had, he would prefer not to take anything.
Great, that helps a lot too. Well, thank you, team, for all those great clarifying questions. And Seth, that was a wonderful history and presentation. We learned a lot about this guy. Let's shift over to some ideas, resources, and recommendations. What are some thoughts that our group here has that might support this guy in his path to recovery? Just open that up to anyone.
Abby?
Mhm.
Good morning, it's Melissa.
Melissa.
Hi, everybody. Question, way back, we had thought that perhaps a member of our team might be able to go out to, someone has been talking about a warm handoff, might be able to go out to meet the individual with the team out in the field. Seth, how do you think someone like this person would feel meeting a member of our team out in the, you know, in their space before they come in to, you know, to our world?
If they've already accepted the appointment to ultimately go, I think they would, this gentleman and just about any patient that has accepted an appointment at a doctor's office, whichever, you know, for whatever reason, whatever specialty, even primary care, I think it would be well received. Because again, it would be, you know, whoever you're sending out with, you know, myself, I mean, it could just be me and your staff member. But, you know, say it's, you know, myself and one of our per diem nurses, we're going out with, you know, a guy or gal from your outfit, and we, again, vouch for them when they're there, you know, this is Bob, we like Bob, you know, and then the patient's like, okay, Bob, and that's, it'll all be history from there.
Okay. So I recognize this may not be a recommendation per se for this particular patient, but someone had said, what would a miracle handoff look like? So in general, sorry.
Absolutely. And even if that miracle would be one of your staff members doing the taxi ride with them and just, you know, being that, because then they've established some alliance outside of your, you know, four walls, and then they're the person that takes them in to say, you know, this is the doc, we like the doc's cool, and you know, you're kind of good to go from there. It's again, it's like it's the trust train. You just hop on.
Right. Okay.
Trust train. I have to write that one down. Trust train. We've got all sorts of Sethisms going on here. That's great. Okay. And thanks, Melissa. Do you want to introduce yourself real quick?
I'm the executive director of Neighborhood Health Centers of the Lehigh Valley, and Abby and I had talked about that idea. I don't know, what was that, Abby, like 6 years ago?
Yeah. Thank you. All right, other resources and suggestions. I see Erica there. Jump right in.
I have a question. Was he ever referred to host when he was in the hospital? Like, was there a level of care?
Yes.
Okay, so he was connected to our system. So the halfway house, was that the recommendation from host, or was that what he was comfortable with?
Host recommended inpatient. I mean, he certainly met criteria,
right?
But we couldn't, you know, they couldn't find anybody to accept him. So I checked with a couple of, I checked with is it Stevens House, where they do accept patients on MAT, but they are completely filled. You know, and that might be a place that perhaps if a spot opened up, if a bed opened up there, that might be, you know, I thought a good place for him. I think he's good at his nieces, but yeah, host did see him.
He met a lot of people during his inpatient stay. He got a lot of
Very popular.
So I think what I'll what strikes me here is that I think host is such a phenomenal resource, and sometimes where I feel like, and we're seeing this here, where that standard level of care assessment that of course is going to designate that he go inpatient sort of falls apart, right? And this is where Abby and I talk about this a lot, like how do you create low barrier access to care? And I feel like Seth, you and Nani and the whole team are the right people to help us better understand that, right? That we can't just say, oh, we fit people into boxes, we get the level of care and off they go to White Deer Run, and so easy, right? And it just doesn't work in cases where there are multiple barriers. You see that, the vast majority of halfway houses refuse people on MAT. I've actually seen that at some of the shelters. They won't accept patients on MAT. We had that at Safe Harbor recently. So how do we think outside the box? And I don't think we can solve that today, but speaking of miracles and dreams, I would like to try to envision a way that we bring MAT to the people, and through a mobile approach. Like I don't see any reason why we couldn't bring MAT and CRS support to a person wherever they are, whether it's in an encampment or at their niece's house or while they're in respite, and just throw out the rest, like throw out the standard level of care assessment, throw out the standard shipping people off into detoxes, and find a way to let this man's life inform our approaches, and just say, let's meet him where he is. And I would like to really be part of trying to envision how we would do that. And I know, Paige and I and others have joked about an MAT RV that we want to have that would cover the region. So anyway, that's just my trying to think outside the box, and seeing patient after patient who meets these same barriers that I would love to find a way where we can make that happen on a sort of a mobile, like a hub and spoke approach. So I'm curious, Seth, how that feels to hear that. Like what, is that, how would that work with the street medicine approach? I feel like you guys get that. That's what you do. So how do you extend that to include addiction treatment, MAT, sort of, peer support, et cetera?
I think it's a great point. And throughout our time here in the Valley, from the start with Brett, the saying goes is just, kind of let the streets teach you how to run the program, because, we kind of decided how to care for patients rather than allowing them to have a voice in the criteria, or, who gets what and what is made. We kind of make it for them and push them into the, triangle hole when they're square. And down in Philly, they actually have the Butte bus. So they have that mobile, unit that goes out to camps and anywhere that, Suboxone's needed, this and that, and they do the mobile thing. So that is up and running down there. I haven't talked to the ladies running it for a while, with all the COVID thing going on, but it's happening. They do it. They're successful. They presented at the International Street Medicine Symposium in Rotterdam 2 years ago, and it was quite impressive what they're doing. And ultimately, it's not just a homeless issue. So as far as going to the people, you certainly could go to people's houses and this and that, and take care of them there. It's just, we do home visits without the home, but I'm sure you can still do home visits where people aren't, because transportation is not just a barrier for our unsheltered population.
Thanks, Seth. We have about -1 minute, but last thoughts on any resources or suggestions. Don't know if anyone else from the NHCLV team wants to chime in on the other end of the warm handoff? Or
Hi,
any
Abby.
other suggestions? Yep, Gina.
I'll chime in. We actually do work with this patient. Recently, he came to the COE, and one of the suggestions that the team actually discussed him Friday during our meeting to sort of come together interdisciplinary and troubleshoot. And one of the suggestions that we came up with, and that Carmelo, his case manager, is working with him on, is getting him into step-by-step transitional housing, because he meets criteria for that based on his mental health Access 1 diagnosis. And I believe Carmelo and I spoke yesterday, and this patient seems on board with that and was kind of excited about it. So we're trying to get him an intake there. It will be an independent apartment for him with staff 8 hours a day that will help him take his medications, teach him some psych rehab skills, and help him get to his appointments, and also just be supportive in general for him. So we think that would be a really good start for him and a pathway toward independence. And they also accept anyone on MAT. There's no stigma around that there. That's not a problem. They're very collaborative in terms of working with the other agencies and providers in patient's life. So that was my recommendation on Friday, and that's my recommendation today as well, to try and get him into some stable housing now that we have him on MAT, and we're sort of taking care of the noise that withdrawal and dependency creates. Now we want to take care of that other hierarchy of need with housing, make sure he feels safe and stable, and then we can start to sort of work on the rest of the puzzle with him and try to empower him and advocate for him to make some good decisions and get him on a path where he's happy and comfortable again.
Thanks, Gina. Seth, thank you for a great case. For the rest of us on the Zoom, if you think of more wonderful resources, you can plop them in the chat. We'll record them that way. And also you can email me, and Jasmine and I will be putting together the recommendations and posting those on the ECHO website at NHCLV by the end of the week. So Seth, thank you so much for giving us such a great case and a lot to think about. Yeah, Melissa, I'm gonna put our...
Yeah, if you share your screen, it'll probably be easier because I just have it as a PDF. So yeah, that'd be awesome.
Okay.
Thank you.
Oh, wrong one. Sorry. Okay. Try that again. Right?
Mm-hmm.
Such a learning curve in this little universe here. Okay. So it keeps wanting me to resume the other slideshow. There we go. Okay.
Awesome.
So we're talking about an intro to motivational interviewing, and our struggle, and Yamalisa knows this is the big challenge, is that we're trying to pack a lot of information into a tiny amount of time.
Yes.
So
Hi everyone. So this is a beautiful segue into our presentation today. I've been now in the field going on 14 years, and in the last year I've seen a huge amount of growth in the network and in the Valley. So I am so proud. You have no idea. This is amazing. The case last month and then today with Dr. Campbell. You guys are just doing an amazing job. And looking at motivational interviewing, we can go on to the next slide. So overall, we're gonna, the objectives of today is, of course, learning what is motivational interviewing, what are the stages of change, and how to begin implementing motivational interviewing. So motivational interviewing itself, it even though every single patient, of course, is an individual, it's probably the closest thing to a one-size-fits-all, one-size-fits-most approach, because ultimately the goal is to elicit and strengthen the person's own motivation and commitment to change. So it really is, patient-centered. And of course, the approach is very compassionate, collaborative, person-centered, and we may guide the conversation, but it's still the patient's motivation ultimately. So really, the patient has the autonomy over what their treatment will look like, what the conversations really will look like, what type of help they're going to be accepting, and they'll be able to make an informed choice and decision as far as what will be the next step for them. And you can go ahead, Abby. So looking at the stages of change, I do want to interact a little bit with you guys. If you can share with me, and I know when I did this presentation last year, the team was a little bit smaller, and also it was still, on a different end of the learning curve. I think we're in a much better place, which is beautiful. So if I could hear from a couple of you, what does pre-contemplation look like? Just one example. Anyone?
The person feeling like they don't have a need to change their current behavior at all and don't see a need for any behavior modification.
Exactly. Thank you. So yes, I mean, it's being either unaware or unwilling to make a change, and it's exactly that. It's just not even recognizing that there's a problem. Therefore, they just they don't even want to consider the change. How about contemplation?
Thinking about it, but don't necessarily, or hasn't necessarily conceptualized the means of doing it.
Great. So, there's that little bit of acknowledgement that there may be a problem, and there's still some ambivalence during that time. And preparation. Faculty.
Beginning to make plans for change.
Perfect. So there's a level of commitment that happens in preparation, and that beginning stage is important. So after recognizing that there is a problem, then of course is preparing to make some sort of change, to make some sort of decision and commitment as to how that's gonna look like. Action.
Following those steps towards change.
Perfect. So then we enter into the actual habilitation piece. We talk a lot, or used to talk a lot, and I know the language is changing, about rehabilitation. And the reality is that for a lot of our patients, it's more of habilitation. It's really learning how, as opposed to returning to. So there's, some modifications to some behaviors, to some thought processes, things like that. Maintenance.
Continuing the healthy behaviors to prevent relapse.
Great. So once, they've accepted that there's a problem, they've prepared to make the change and implemented some of those things through the action stage, then of course, then they enter the maintenance, which for many, of course, we hope that that's the longest phase that they stay on. It's, that's long-term recovery for many. Recovery looks different for everyone. However, it's a work in progress, of course, but it's still working working whatever the program looks like for them. Now, how about relapse?
Once again, engaging in drug use. This could be due to a trigger or a life event.
Yeah, it's kind of entering into like a crisis mode, and really relapse, that this is not the order. And if you can see the little arrows, it's kind of back and forth. It doesn't always happen in this order. It can shift, it can occur at any point in time. So any type of crises, any type of stress, any type of occurrence in their life, it could be gradual. Behaviors can start shifting in many different ways. It could appear suddenly for many people that maybe don't know the patient. So I think that's why it's very important to get to know your patient and have a relationship with them. But complacency also happens in this stage. You know, they could, and again, they could be in maintenance, they could be in contemplation, they could anywhere. Relapse can happen. I think. Go ahead, Abby. Okay, so when we talk about the motivational interviewing roadmap, you know, there's some stages that are presented, and, you know, engaging the patient, focusing on their needs, evoking some thought, and finding out more in-depth information, and then of course making a plan for what that looks like with them. If, you know, as listening to the case, I think we were able to see all of the stages happen, which was beautiful. You know, this roadmap was kind of walked right along with the patient. But if you were to share, what does engaging look like in your practice for any of you that have patients? And again, over the past year, I've seen a ton of growth, which is absolutely beautiful. So when you engage a patient, what does that look like for you?
I think Seth just gave us the most beautiful example of meet someone where they're at, don't cry, and let them tell you what they need, right?
Absolutely. And again, when I did this last year, one of the things that we were kind of like hammering in, like, when it comes to entering motivational interviewing and the learning curve that comes with that and the process of it, one of the things that was seen often is that the physician will take basically just that brief advice role. You know, there's different kinds of interventions that happen with motivational interviewing, and it would come from a space of almost authority. You know, it was that inequality of roles. Like, it would be very focused on the problem. It would be pretty much like expert advice. And just providing information as opposed to asking questions. So then we have, you know, other ways of doing it, more of the behavior change and task-oriented method. However, the one that seems most effective, which I'm seeing that it's being utilized and it's beautiful, it's the high quality listening. Is really just kind of asking an open-ended question and allowing for the individual to fill in the blanks without presenting the blanks, if that makes sense. So I think that's, you know, something really, really amazing that's happening. So it's inviting for the individual to look at new perspectives, kind of giving some suggestions without you know, pushing your own agenda, basically. And any kind of response that's given should be accepted, because that's their reality, that's their story. And it's pretty much just, you know, a dance that happens between the patient and the physician, or the patient and the CRS, the therapist, etc. But it's definitely a collaborative effort that occurs. Okay. So we go with, so the toolbox for motivational interviewing. And of course, as we really just kind of talked about that. It's the being, it's, you know, looking at the individual, it's collaborating with them, the evocation, and, you know, identifying that they're autonomous. This is their life. This is their recovery. This is their process. You know, most important is to strengthen our core competencies as we begin to use motivational interviewing. It's being empathetic to the individual, you know, avoiding arguments. And again, it's kind of just rolling with whatever they have to say, rolling with resistance, you know, develop discrepancy and support self-efficacy. So really, it's just our job is to stand beside or behind them and kind of, you know, push them forward in their process. And then some of the techniques, as I mentioned, is of course asking those open-ended questions and allowing for the patient to fill in. It's affirming their strengths. That's huge. You know, we're very quick historically to just focus on the negative things, but it's important to identify the positives that the individual are doing. We may see it as small, but for them, it could be the greatest thing that they've done in that day, and we should applaud it because they are still here. They're still with us, and they came into our space to speak with us. So even just acknowledging that they came in today, it's something beautiful. Of course, reflective listening. Let them know that you're paying attention. Let them know that you're listening to what they're saying. It's not about repeating and mirroring everything that they're saying. Of course not. It's more of, I understand what you're saying. This is what I'm hearing. Did I hear you correctly? And kind of let them, ask the questions, and you yourself be vulnerable to be corrected by the patient. Summarizing what they're presenting to you, again, is just a way to show them in your own words what you heard, and then allow them to correct you if you're wrong. And then of course elicit change, and it's that we can provide suggestions and allow them to choose what would be the best way. So as we are looking at the stages of change and the motivational interviewing, or through the process of motivational interviewing, of course, we have the stages that fall into what we are doing now. And again, it's not one size fits all, or every recovery looks the same. However, most of the time, in the stages that this enters in is the pre-contemplation, contemplation, and preparation. Is more of the creation of that plan, is discussing where the individual is at, meeting them where they're at, and kind of creating, a smart set of goals for them to move into the action stage. Now, treatment, again, can look very different for every patient. Treatment for most may have been in the past, like we were saying before, kind of filling in those boxes of, you meet criteria for inpatient, so that's where you go. And then you come out and you go to IOP or to partial, and then you move down the line. And that's not the reality. That method does not work for everyone. We have individuals that have, that have children, that care for elderly parents, that have, other situations going on, that they don't have the ability to enter inpatient treatment and be, substance free in that type of environment. So I'm happy to see the MATs being implemented at more levels. And then of course the relapse prevention and management happens in the maintenance and or relapse stage. And again, relapse can happen anywhere in the continuum. So how do we begin? How does this happen? Like, how can we get it started? And first is for us to check in with ourselves, for us to recognize that we don't know it all, that this is not our recovery, and it's not going to look the same for each patient. And of course, just being humble. It's really taking a couple seats, as we say, being curious. And not in the prying type of curious, but just in, that intrigue and open listening. As well as we ask open-ended questions, we should be open to listening. Don't judge. And one of the things working in the substance use field, and I'm sure anyone can say this that has been in this field for a long time, our patients are really, really good at reading our expressions. They are amazing at knowing when they're being judged. They're great body scanners. So we really need to check in with ourselves, and then of course assume nothing. Just because you may have heard a similar story does not mean that this story is the same. And then of course, when it comes to the patient, is understanding that in this setting, the expert is them, not us. So we are no longer the experts. We take a different role in these conversations when it comes to motivational interviewing. Our goal is ultimately to uncover their expertise and identify that, affirm that, and then help them grow from there. So before getting lost in all of this, motivational interviewing, it's really just creating a checklist for ourselves. And it's asking those questions first. Have I asked questions? Am I curious about them? Truly getting to know them. Do I understand what their values are? Have I asked about their aspirations? And really just knowing, are we doing that? Are we really engaging the patient and seeing the patient as an individual and really making a connection with them? And then, of course, as we get the answer to these questions, then move into our MI toolbox that we discussed. Okay. So some of the questions that can be asked as we get to know and build some rapport with our patients, of course, is, what was their childhood like? And we were able to see that today. That was one of the first things that was presented in the case is, I had a good childhood, and how the individual felt that his childhood was. What does a day in their life look like? And just finding out. Our days are going to be very different. Their routines may be very different, or it may be actually absolutely the same, just, a couple things different, but being okay with asking these questions. So who do they call when they're in distress? Who do they have? And this is more of, and many of us have seen them, is creating a crisis prevention or relapse prevention plan with the patient. And again, it's an individualized plan based on their responses to a lot of these questions. So who or what do they, what do they love? What do they like to do? What motivates them in general? Does your patient have any hopes or dreams for the future? It's important to be in the now. However, it's also important to know whether they're seeing themselves moving forward, and what would that look like in their eyes. I know we spoke about miracles. I know we spoke about, ideal situations, but it's really knowing what is their ideal as opposed to ours. And what cultures, what culture that they belong to, and not necessarily just an ethnic group where, we're speaking. It could be from language, food, religion, politics, careers, many different ways that the cultures do get developed, and we express them. So we can identify ourselves to be in a culture that maybe, the patient doesn't understand, and vice versa. And it's okay to ask those questions and allow them to elaborate. So it's finding out, what motivates the patient. Ultimately, that's really what we're getting down to as we ask all of these questions. Everyone has motivation. It's just, it's internal motivation. And that's why, we're doing this training, is to understand what motivates this particular individual. There's no such thing as an unmotivated individual. It's just, we may not understand what their motivation may be. We may not understand, where it comes from, and that's okay. It's accepting that we don't know all of that, and they're the expert, and we need to remember that. Everyone has core goals and values. There are things that are important to each one of us, and that's what we're looking to find. When it comes to the hierarchy of human needs, it's understanding that, of course, we have the physiological needs, the basic needs of food and air, water, and then having security, but also love and belonging. One of the things that happens often in the lives of our patients is, feeling unwanted, feeling unloved, feeling they don't belong, feeling alone, and is, again, meeting them where they're at, finding out what motivates them, or what would belonging look like for them, and helping them achieve that. Working on their esteem, their self-esteem, and then, of course, self-actualization. It's working on, like we were saying before, it's what is their goal? What does their future look like? What is moving forward? What's the next step? And allowing them to identify that, and then for us to help them achieve that. So when we look at the, I mean, and we just kind of went through that, the hierarchy of needs. So how do we, how do we start that? And it's really just ultimately by understanding your patient. You're asking these questions, you're already using motivational interviewing. If you are curious, if you're in, and here are the processes. So if you're engaging them, if you're engaging the patient, if you're asking questions, if you're focused on their needs, if you are providing feedback that really gets them thinking and gets them going, you're doing a beautiful job already. And if you're helping them plan for what their next step looks like and helping them achieve their next step, then you're successfully applying motivational interviewing. So that kind of goes through the same steps. Okay. So some of the ways that we can find out whether the individuals are ready to make a change is just asking a couple of these questions. Simple enough. On a scale of 0 to 10, how important is it for you to blank, whether it's to enter treatment, to receive MAT, to stop using, to whatever, some of the things that they may have identified. And that's where that reflective listening comes in. Hopefully you heard what they identified as it being important, and then for us to kind of help them place it in a level of importance, and then we can kind of tackle one or two things at a time. So again, how confident are you that you can do blank? And let's, for example, here's an example. Let's say that the patient answered 3. Now asking them what's going to take them to 4. And just as simple as that, that's not prying. That's a beautiful way of asking a question and allowing them to tell us, it's not asking them, okay, let's get you to 10 today. It's, you're at 3 today. How do we get, how do I help you get to 4? What do you need from me? And allowing them to teach us how to help them. So far, I mean, as you guys are listening, what would be some of the ways that some of you feel that you could implement, the steps in the toolbox? Like what would collaboration look like? What would autonomy look like, or evocation? Someone? Anyone?
Hey there. So I think just being, like, I love that word, just being with the patient and meeting them where they're at and just walking alongside them is so powerful. I think a lot of times when we meet these patients, they feel very powerless. So giving them that power and saying, hey, I support you, I'm here. Like, what next? What are the next steps? Let's do this together, I think is pretty amazing.
Yeah, I think also leaving your own agenda at the door, because I know when we come to care for patients, we come with our own agenda. Like, this is what I want to achieve, 1, 2, 3. Just leaving that at the door and letting the patient kind of develop their own, their own care plan and their own path for their health and mental well-being.
Beautiful. Thank you. What about how do we work on developing these core competencies that are so important when it comes to motivational interviewing? Any suggestions?
I think really being mindful of them. Just remembering that's, if we're doing the collaboration and going to where the patient is, to really make sure that we're kind of following that path of what that really means in terms of working with the patient, with the empathy and rolling with that resistance, and just avoiding, it's like person previously said, checking your baggage at the front door. Yeah. So that you're not necessarily going to say, get into an argument with them or a dispute with them, but really just continuing to practice it and understand what it means to have that spirit or that being, because it's just very easy to sometimes become frustrated and want to kind of push back. And it's just really, really important that that not happen, because it just doubles or triples the resistance.
Right. And thank you, Bill. So it's important to see, you know, when we talk about role resistance, the reality is that most of the time, sadly, we're the ones posing the resistance. It's not necessarily them. They already walked in our office. You know what I mean? They're already in a vulnerable situation. They're coming into our space, and many already feeling unsafe. And so when we feel resistance, it's probably because, like, you know, like you lady said too, is we're coming in with our own agenda and not allowing them to really create that and tell us where they're at, and for us to meet them there. So that's important.
And I think the patient gets blamed for that too often too. We're creating the resistance, we're bringing that into the session, and then we're blaming the patient for that, as opposed to kind of looking at our role in it and how we may need to check ourselves.
Exactly. Perfect. Then what about some techniques? And again, Dr. Campbell was amazing at showing how, you know, how he was able to do this. But what are some, you know, examples that either you guys have used, or now listening to the presentation, you'd be curious to try some of the questions that you would ask? What would that look like?
I know with the patients that I've worked with in the past, one of the things that I've really tried to have them shift their viewpoint with is saying that, or identifying that they already have the tools. They may not be using them the right way, but they already have them. So all we have to do is just kind of shift their thinking and have them use the tools in the way that will most benefit them.
Perfect. Anyone else?
I think also for me, what has helped is letting the patient guide the conversation, and really just, you know, having a conversation with the patient, not saying like, next I'm going to ask this. Right. Like being present in the moment is really key to having the patient open up.
Perfect. And that's beautiful that you said that, Judy, because it's important to know that we may start the conversation thinking, oh, today I'm going to know exactly what this treatment plan is going to look like, or we're going to set goals today, or we're going to whatever, you know, whatever it may be, or, you know, he or she will enter, you know, inpatient tomorrow. That's not always the case. We need to be, you know, we need to be open-minded to the reality, to the patient's reality, and understanding that they may not be there today, and that is okay. You know, of course, our goal is to first and foremost preserve life, of course, but ultimately is to meet our patients where they're at and give them the best chance possible for their recovery.
Can I say that the tool that's the most useful for me for all of that is having the interdisciplinary team right here, and that having some humility and knowing that when I'm not achieving these aspirations, that I've got team members who can call me on it or step in if I need to step away. I mean, having the team really makes this better, as long as we're able to really communicate with each other about how are we doing with our spirit of motivational interviewing today.
That's beautiful. And knowing that this could be, you know, very shameful conversation to have, especially with your physician. You know, what was the last month, we had, you know, the patient come in, and the history was really not known. You know, it may have felt like it came out of nowhere, like, oh, by the way, I'm using all of this and I need help. But just the fact that they opened up about it, it could be very difficult. And when it comes to a physician, you know, you guys are all in a place of authority over any patient that walks through your door, regardless of their history. It's not just about substance use. So speaking to a peer, or speaking to, you know, CRS especially, the level of comfort, the walls will basically crumble right around them, and they'll be able to identify in a different place. So for you guys to recognize that this is not your forte and that is okay, that's probably the best way that you'll be able to use motivational interviewing, is checking in, you know, your own biases, and understanding that humility is important, and tapping out when it's not your space to enter, basically.
Can I add something?
Yes.
So on the recovery aspect of it, I'm really their biggest cheerleader. Like it's you know, I was speaking to a woman the other day, and you know, I used too much of medication, and I hope they didn't know at the Zoom meeting that I was high. And I said, wait, so you actually made the decision. So what I hear you saying is you made the decision to go to a Zoom meeting even though you were high. That is amazing. Right. You know, like most people would not even, and going to Zoom meetings, especially right now, when I talk to anybody in recovery, you have that choice of getting online, you know, so doing that. And she said that she actually had her video on, and you know, like celebrate those, you know, what she thinks is, you know,
a
failure, celebrating that, but you didn't have to, you know, and just really reinforcing. And, you know, and I get that, you know, text from her later that says like, thank you for being my cheerleader. And I said, you know, that's really what, you know, like, I'll be your hype man all day. That's fine. You know, and just, and keeping it really personal for her was, and that's really where I come from. And, you know, and really letting her guide that. And I never really thought of it that way. Well,
you did it. Yeah.
I did it.
Thank you. That's amazing. And it's that, you know, as we were mentioning earlier, it's understanding that we may miss some of those, you know, achievements, and it's our job to really check in and see that that's a big deal. That's a big deal to still choose to walk into these spaces, to access these spaces, and put yourself in a vulnerable situation where you don't know if you're going to get in trouble. You don't know if they're going to call your PO. You don't know if you're going to whatever, you know, if people are going to call you out on it, because you're meeting with your peers, you're in group, and you're speaking to other individuals that have done this as well. So it's uncomfortable. And yet she made the decision to still make that call and still put on her video and still participate in group. And yes, that should be celebrated. So, you know, in summary, it's just, you know, allowing the patient to identify where they are. It's their own motivation to change, whatever that may look like. It's for us to be accepting of that, is to, you know, allow for it to be created. It's sort of just this, you know, beautiful collaboration that happens between the patient and the physician, or the patient and the therapist, patient and the CRS, nurse, etc., everything, caseworker. And being okay with what that mosaic looks like, because it's still beautiful. You know, motivation for change it's malleable. It's formed in the context of that relationship. You build that relationship, and then that's where it's going to develop from. You know, I don't know if any of you guys ever made like sugar crystals. There's no two that look the same. You may put the same amount of sugar, you may put the same amount of water, the same amount of food coloring, flavor, whatever it may be. But once it starts sticking to the string or the stick or whatever, the way that it comes out may be very different one from the other. The shades may be different. The way it shines in the sun may be different. It's still beautiful. And then just, you know, creating those connections, and learning what is it that your patient cares about, and helping them see how those are strengths, helping them work from there. And we all, you know, tend to really tell ourselves that we need to make the change for them, or identify how to change, how to work. And the reality is we don't. That's not our job. Our job is to strengthen and recognize the strengths in our patients, not in tell them how to do or when or where. So, you know, we tend to, and here it says, we all tend to believe that, you know, what we hear ourselves say, that elicits change talk in our patients. And it may or it may not. It really just depends on how we approach it and how empathetic we are through that process. Any questions? Any suggestions or anything else you'd like to add?
I think that was wonderful, young Lisa. Thank you for sharing that. And there are a lot of tools out there to help us dig deeper into motivational interviewing. I think the more I learn about it, the more I realize how much I don't know about motivational interviewing. I don't know if you want to say anything about the ASAM workshop for motivational interviewing or any other quick resources if people want to learn more.
Yeah, sure. So there is you can become motivational interviewing. You can become trained by Mint, the organization, and you can look at motivationalinterviewing.org. And it's an interdisciplinary training. It typically happens once a year, and it gets pretty full. You become trained under Will Miller himself, and they happen on a different continent, I believe, every year. And then you go through an intensive supervision and training process that year back at home after the training. I think to get into one of those trainings, it's about a year waiting list to get to the training. And then you go to the training, you spend about a year diving deep into your skill set. The American Society of Addiction Medicine also offers training on motivational interviewing on their website, on their addiction series. But the other thing that I'd say, Yamalisa, you did a great job, is just watching yourself work is a really powerful tool. And so if it's something that, you know, you're integrating a lot, starting with the oars, like focusing on, there's a whole advanced skill set around MI, right? And so if you like say, I'm going to work on integrating the readiness ruler, and watch yourself do it. And, you know, if you can watch yourself work, if you can tape yourself work, or I'm going to just practice implementing the oars, open-ended questions, affirmations, reflective listening, and summaries, and just grounding in those when you're with the patient and really just gaining some traction and some depth around those skills, because it's really tempting once you start paying attention to just be in assessment mode, question after question after question, and to notice like how, you know, the spirit of the work can sliply escape you. That's all.
Thanks, Angie. That was great. So we can think about motivational interviewing. We have another case, and I see that Drew has joined us, and some other people have too. So I just want to give folks a chance to say hello. So I'll call out some of us who joined a little later, and if I miss anyone, chime in at the end. But Erin, can you unmute yourself and say hi? Just introduce yourself briefly. You're there. Really cute photo. There she is. Okay.
Good morning, everybody. My name is Erin Smith. I'm one of the physicians over at NHCLV, and I also work inpatient over at Lehigh Valley. I've heard about ECHO since my residency here, and I'm excited just to be a part of it this morning and listen in. And I'm learning a ton, and it's really neat to be with so many wonderful people. So thank you guys for the opportunity.
Thanks, Erin. Chris Nye.
Good morning. My name is Christopher Nine. I'm Behavioral Health Clinical Coordinator with the Community Care Team.
Wonderful that you're here with us. What's Elaine? You're on mute. You unmute her? There she goes.
Sorry, somehow I managed to minimize the window while trying to unmute it. Well, good morning. I'm a family doc at Citronia, and I'm glad to be able to listen in and hear the case this morning.
Thanks, Elaine. We're so glad you're here. Drew.
Good morning. I'm Drew Keister. I'm the Vice Chair for Education at Lehigh Valley Health Network, and I practice at the Family Health Center.
Yay. Mary Beth. Hi.
Good morning. My name is Mary Beth Kohler. I'm the Clinical Case Manager for the Connections Program within LVPG OBGYN.
Really great to have you here, Mary Beth. And did I miss anybody? Is there anyone who hasn't had a chance to introduce themselves? Lori, maybe.
Hi, I'm Laurie Widener, Behavioral Health Specialist with CCT.
Great to have you here. Okay, Drew has a case for us today also. And we've got about 25 minutes. So let me see if I can pull this one up for us. You know, my sharing skills are really great. Okay. All right.
Good morning, everybody. Thanks, Abby. So the patient that I'm talking about is a 62-year-old Caucasian. I'm looking just for help with a treatment plan for him. I did not talk to him about the presentation, and therefore he didn't help to develop the question. So this gentleman is someone that I've known for about 18 months, maybe a little bit more, but I think that's about right. And I've been caring for him. We'll get into some of the reasons why. He's a gentleman with significant strengths. He's got a stable job in housing. He has home maintenance skills. He works for a, sorry, I'm laughing just because the lights at Casa just dimmed us all. He works at a warehouse type of a job, driving a forklift. But he also has significant skills in home maintenance and helps his family, his neighbors, and in his own home. He has a very caring family, though much of it is distant in Florida. And so the question that I had is, what's the best way for me to manage his pain in light to some of his non-adherence to the non-medical components of his treatment plan and sometimes even the medical side. He does live alone here, but his son's in the area. He's very close with a brother who's in Florida and has what he calls liver cancer. That family is a source of support, but they also need him in some significant ways. And so in the last 18 months, there have been at least 2 times that he's been away for a significant amount of time, long enough that he missed an interval appointment with me, which I'm trying to do about monthly now. His most recent stay was more than 6 weeks. I'm not sure about his education background. I do see a note on his chart that there is a history of incarceration, but I have not been able to investigate that further with him. And I mentioned that he works at Pinnacle Logistics. So just in terms of some of his history, I'm going to sort of jump down to the bottom. He is an everyday smoker. He denies alcohol and illicits. He came to me basically asking for a tramadol prescription. That was the initial visit. He acknowledged at that point that he had been purchasing tramadol off the street for about 3 months because his other primary care physician had moved out of the area. And so he does have significant documentation of reasons for pain. So he is using the tramadol that I prescribe. You can see the dosages there, 50 milligrams, 1 to 2 tablets every 6 hours, a total of 8 tabs a day, which is equivalent to about 40 morphine equivalents. And that pain it's actually primarily in his chronic back, but he has developed over the last 18 months significant bilateral hand pain from what I believe to be ulnar neuropathy. In addition to the time that he had purchased some of the tramadol from the street, which, you know, we know anything marked tramadol on the street is likely not tramadol these days, more likely to be fentanyl. So he also took some of his sister-in-law's tramadol when he was in Florida for the most recent time. He did have a negative urine drug screen in March of this year, but he acknowledged before taking the screen that he had run out for several weeks. Again, this was during the time that he had come back. He took some of his sister-in-laws, but hadn't had any for about a week since he had been back in town. He did have a UDS in November that had some tramadol. And I've ordered a bunch of other labs in his care over the last 18 months, and he has not had them drawn. So there's some comorbidities. I've mentioned the back pain, the ulnar neuropathy. He does have diabetes. He's got coronary artery disease with stents in place. He's got hepatitis C, which is untreated, and persistent dysthymia and generalized anxiety, which he is pretty reticent to discuss in meaningful ways. In addition to the tramadol that I prescribe, he takes aspirin and Plavix, Coreg, enalapril, a statin, some aldactone, and he does take some Wellbutrin, which he says helps with his mood. So this just kind of walks through the DSM-5 for substance use disorder. And you can see that there's some uncertainties here. So I'm not sure how much time he is spending to get the substance. I want to believe that he is taking it only as much as I prescribe and not, seeking additional from the street. And I have no evidence to show that that's not true. But I have some wonderings about that. It seems as if he's doing his work and home obligations. I don't have a lot of corroborating support for that. Again, it's not clear to me what sort of repercussions this may have had, whether his prior incarceration may have been related to something related to substances, and again, he's been pretty reticent to discuss that. He clearly has developed some tolerance to the tramadol. It's the fairly significant dose that he's taking, and he acknowledges when he's run out, he doesn't need as much to come back to it. And he also acknowledges when he runs out that he has some withdrawal symptoms. So those are the pieces that we know there. So the other thing that's difficult for me is that he is really does not like to talk much about his feelings. Though when he's talking about his brother's cancer, he's gotten sort of teary-eyed with me and has shared some of his emotion. But he's portrays a tough guy, sort of affect, and doesn't want to talk about how the pains are affecting him and those sorts of things. And when I have conversations with him about trying to get to the bottom, especially of his hand pain, he saw sent him to an orthopedist to consider an ulnar nerve release bilaterally, and he went once about a year ago and hasn't returned. I've sent him for EMGs and he hasn't obtained them. I've asked him to consider physical therapy, and he when he's with me, he always is yes. And I've tried some of the motivational interviewing techniques, tried to check in about, I don't want this to be my plan. I want this to be something that you're okay with. He has always said that he's invested in the things that we talk about. But then the reality, is he comes back and sees me a month or two later, and is, again, a part of what I feel is that sometimes he's just looking for his next prescription and not really invested in sort of the process of improving. And so I've tried to explore that. The other thing, of course, is that, I'm having these 20-minute visits, right? And in that time, also making sure that I'm refilling his meds for diabetes, although we've stopped his metformin, so he's currently diet controlled for his diabetes, and his other comorbidities. So it's been hard, I've tried to explore another piece of his care is his untreated hepatitis C. I've tried to explore, getting him there, even talked about some of his motivation to avoid the hepatitis, or to avoid, liver cancer that his brother has. And he, again, states, yes, I don't want to do that. But I have not been able to partner with him to help him sustain the actions that we talk about in our appointments. So I haven't really been able to get to the bottom of this. Again, like trying some of the techniques. And so here are the diagnoses that we've talked about for him. Obviously the chronic back and ulnar neuropathy pain being the most pertinent to the pain control question. Pretty much his goals when I talk to him about them are to get his pain better. And he acknowledges that the tramadol doesn't do that entirely, but he says that it's way better to have it than not. And so that is what I've been able to delve into in terms of his goals.
Thanks, Drew. So let me give this one a try for a sentence that's a bit of a ramble for him. You've got a 62-year-old guy who's got chronic low back pain and pain in his hands. He's got some other chronic physical and mental comorbidities. He's a little bit guarded, has lots of strengths, but has been using tramadol off the streets and from his family, and somewhat unclear what his investment or motivation for any kind of comprehensive plan for his pain, or exactly if he has a diagnosis of opioid use disorder. And so the question is, what do you need to change to be able to help him meet his goals of better pain control and improve his life? If you're feeling a little stuck and frustrated.
Exactly, yes.
Yeah. So, clarifying questions from our group for Drew. What are some of the things we might want to know about this case? We got all the plans we need right
I
here.
have a question. Has he seen a therapist in the past, and are you the one prescribing his Wellbutrin?
I am prescribing his Wellbutrin, yes, and I have talked to him about seeing a therapist, and he has not been interested. So, I mean, I'm open to the idea. You know, I'm really reticent to tie his, you know, I want him to have a comprehensive pain management plan, and I do believe that counseling would benefit that. But one of the things that I worry about with him is that if I start putting sort of, I won't give you this unless kind of features on it, then he will, you know, those barriers could be enough to push him to, you know, going back to obtaining it from the street. And I think what we're doing now is better than that. So, it's a challenge.
So I guess the question I had, it's Gail, has he done any other kinds of like meditation or any kind of exercises to improve his management of pain?
I have approached him about those possibilities. I've talked to him about sort of chronic pain support groups, and you know, several different modalities. And he is he says, you know, I don't have time to do a lot of those things. And that's often when I can get him to say, you know, why he didn't follow up. It's often he feels that he is very busy, and it's hard to find the time to
do
fit
those
in.
things.
Exactly. Right.
Okay.
Drew, did you? I know you already did this, but I got to ask you anyway. Did you go through and sit down with him with the treatment agreement and sign it together and sort of use that as a basis for your conversation?
Yes, absolutely. Yeah, thanks for asking. And you know, again, this is one of the things that I struggle with in terms of this treatment agreements, right? I mean, technically, according to the agreement, he has violated it by not following up with orthopedics, by not doing physical therapy, you know, and so my training would tell me, the way that I was sort of brought into approaching, you know, management of narcotics for pain would be that he's violated. I should cut him off. I should weed him down. I should, you know, get him off. And I'm fairly confident that doing that would you know, worsen his health. So that's where I'm a little bit caught, you know.
Yeah, I like to think of the treatment agreement rather than sort of as a gotcha, just sort of a guide.
Right.
And so certainly incorporating like the PEG tool on a regular basis, and from the outset, from the treatment agreement, saying if we're not really seeing an improvement in pain and function, you know, these medications, the risks really outweigh the benefits, and there's different, better ways we can approach your pain. And so that framing it that way would be an opportunity to, you know, taper the tramadol while offering different medications. And sort of as an aside, I definitely, I mean, this is obviously a very challenging case, but I'm really really explore more the hepatitis C. You know, it's such a, I mean, you know, the consequences of
oh yes,
such a. I know you know all this more than I, but it's just it's such a concern to me. It's such an easy treatment with such a phenomenal success rate. I'm wondering what's the barrier there, you know?
Right. No, exactly. I agree 100%. And it's one of the things that I worry about. One of the reasons that it's been sort of circling in my mind as I've been listening to other cases in the echo is because there's an element of sort of inertia that sets in, right? So the first 5 times that I talked to him about going to the hepatitis clinic, I had a lot of passion for that, and was really trying to you know, get to the bottom of that, where that resistance was and all of that. I feel like in some ways I feel like I'm being put on that pedestal that sometimes we are asked to sit upon as doctors. You're the doctor, you tell me what to do, right? But in a lot of ways, when I'm put there, I feel like that prevents a partnership from forming, right? So it's always me in the paternalistic role of saying this is what you have to do, and when I try to kind of step down from that and say, no, look, you know, I've referred you 5 times to the hepatitis clinic and you haven't gone. So what I say from this pedestal, it's not what you're going to do, right? So let's actually talk about what you can do. You know, I want to hear from you. What are the troubles? And I just haven't been successful with getting to it. Yeah.
Let me.
I just have one other thing, Abby. I think, you know, and like you said, you don't have a lot of time with this patient to get those 20 minutes in the visit. And I think, you know, incorporating now the enabling services, as we call it here at 17th Street, care manager, behavioral health specialist, you know, you're not throwing these things at him and making him, you know, talk to us, but we do have a certain approach that, you know, even when I call the patients, it's very down to earth. You know, I have that time to kind of have that patient open up and try to talk him through these barriers to at least get him his labs done, EMG, you know, right, and step it to where we want to get him.
I agree 100%, Judy. The trouble is if he doesn't pick up the phone when you call, you can't you can't do it, and that's been
but
experience.
I can show up to the office visit when he's here.
Okay.
We got a couple, like 2 more minutes, so I'd really like to hear from some more of our CCT team members or somebody else out there from a behavioral or peer point of view. What do you think might help get in this space to give a little more room for Drew and the patient to find a path that's going to work better for them?
Drew, it's Melissa. I was just wondering, and I don't know how this might appear to him based on your relationship with him. What would happen if, like, you just extended your visit with him a little bit and maybe asked someone from the hepatitis clinic to come down during your visit time and almost, like, I don't want to say take over your time, but maybe that clinician introduce, you know, you kind of do almost like a warm handoff during your clinical time so that they can introduce themselves and maybe talk a little so that you can, like, explain subtly, like they can explain the difference between what would be the clinical care offered through that specialty clinic and how you two would partner together. And maybe if he saw that in action, maybe that would allow a slightly different perspective, since he doesn't want to seem to give up extra time, but he's willing to give up the time it takes to come see you, right? And whether or not that's just to pick up the script, right? It's an opportune time.
Right. No, I think that's a great point. And Judy, I'll connect with you offline. I mean, I love the idea of a warm handoff for both of these you know, sorts of things. So yeah, I will definitely, you know, see what we can do with that. You know,
Yeah.
I'm willing to try.
20 minutes though, so I know it would have, you know, it would require you guys to block off a little bit of extra time, probably.
Really interesting suggestion. And again, for this case too, if you have more thoughts, you have a couple of seconds to put it in the chat or email me, and we'll include those suggestions when we send those out and post them on the NHCLV ECHO website. But that's a great case with lots of food for thought, and trying to think about how do we do things differently when you feel stuck. It's our teams that are going to help us get through this. So let's do a round of one-word checkouts. I'll call on you as we go, but just one word that you're taking with you from today, and we're going to start with you, Drew.
Thanks.
Right.
Hi. Yeah. Again, thank you. Great presentations. Thank you, Seth. Thank you, Dr. Keister. I agreed. Please utilize the VHP enabling services. I really feel that Judy and Tommy at FAC can really help this patient. Excited about the work we're doing here, and I'm glad I'm part of this.
That's great. Gail.
Oops, let me see. Oh, yeah. I think the team, it's just so wonderful to see people connecting with patients and with each other. So thank you.
Thanks, Gail. Annalisa.
Proud. Do you hear me?
Yeah.
Okay.
Oh, what did you say? I missed.
Proud. LVHN is doing a beautiful job. Proud.
Thank you. Christopher.
Encouraged to keep going and carrying forward this work.
Thank you, Christopher. Angie.
Thank you, everyone. Community.
Elaine.
Not one word, but I really enjoyed the motivational interviewing presentation, so I guess sort of non-judgmental.
Erica.
I sit on several of these collaborations, and it always gets me, you know, thinking towards the future is what, you know, I think of whenever I leave one of these.
Future. Great. Oops, I just went too far. I think after comes Gina. Yeah, thanks. They just changed order. Gina.
Hi, sorry, I was writing a chat. My one word today would be acceptance in terms of meeting the patient where they're at with motivational interviewing, and also in terms of the presentation we just had. I was sending a chat about embracing and accepting chronic pain, and therefore dispelling that a pill or illicit or prescribed would make it go away, and what would life look like if he accepted it.
Thank you. Jessica Morris.
I would say informed. I think there was some great information in the cases presented today, and I definitely know that I got some good tools today that I will definitely use. So.
Thanks, Jessica. Jessica Deemer.
I'm really grateful to have this perspective and this learning experience. It's been so wonderful being able to listen to all of this, so thank you.
Jill McCambridge.
I'm going to say empowered. We empower our patients all the time, so I think it's just as important to empower each other. I think that helped today. Thank you.
Giving each other some power here. Judy.
Supported.
Oh, that's the goal. That's great. Kevin.
Educated.
Lauren.
I just wanted to say that I really enjoyed the presentation on motivational interviewing because that'll help my project a lot. And it was just great to really hear the cases and get all these different perspectives on everything.
Mackenzie.
Grateful. Thank you all.
Mary Beth.
I'm feeling very motivated after this. So thank you. Much appreciated.
Excellent. Paige.
I'm impressed. I'm really impressed, and it's an affirmation that we're a great team doing a good job.
Sophia.
Fortunate. I feel very fortunate to be a part of this team. I feel very fortunate to continue to learn and continue to grow. So thank you, everybody.
Yamalisa. Yamalisa already, but you appeared down at the bottom of the list. All right, Jasmine. Let's go with Unity. Naomi, motivation. And I think I'll close us out with, I feel embraced. All right. So we will be sending out emails to everyone. It will have the recommendations and resources, the link for the survey. Please do the survey. That helps us be able to maintain the CME and the CEUs. Please, if you haven't already, send your name the way you want it to appear on your certificates. And we will see you next month, same time, same place. What date? 3rd of the month. The 15th, July 15th will be our next echo. See, I'm right on that. All right. Have a beautiful day, wonderful people. And then Melissa and Angie are going to stick around for a minute, right? Okay, here's us. We had over 36 people.
How many people, Abby?
Over 36. I think it was 36 total with all the sort of flowing.
Whoop, whoop.
That's pretty cool.
That's awesome.
Mm-hmm. Melissa, thank you. That was really beautiful presentation.
I was so nervous.
Were you?
But I mean, I always get nervous every time I'm gonna speak. But I think putting the case prior and then just hearing, I was like, oh my God, that was such a beautiful case. Like, it was perfect.
I think it kind of took everything off you.
So I didn't hear you, Naomi.
I think it took a lot off of you in the beginning. So you kind of I think that was actually nice. So I think if we have 2 cases like that, taking the recognition right off that person with the didactic, yeah, it kind of helps. I think the sandwich works. Yeah, I like it that way.
It definitely worked for me because the kids were still here for that first half hour.
That would have been kind of funny.
That would not have been a good presentation.
Right.
So it
Yeah,
worked.
and it worked because Seth had a meeting at 8, so he could only come at the beginning, and Drew had a meeting at 7. He could only come at the latter half, and I think that's another little piece of validation that if we're trying to meet people where they're at, that the sandwich is a good idea.
Yeah. Was it okay to do the interactive with the team and stuff?
Yeah. Yeah. And I think that the timing worked out okay. I think in general, I might want to see if we can, and this isn't on you at all, young ones. I'm just sort of trying to think that, those didactics are designed as sort of 45 minutes, and I think we want to cut them down a little, right?
Yeah, and I figured when I saw that we were already at 8 o'clock, I knew I wasn't going to be, because I have 5 pages of notes, and I'm like, oh, nope, not today. So.
And so barely scratching the surface of motivational.
Yeah.
It's a nice intro though. You know, how do you get started? I think it's not bad, but I know Andy, you and I have been talking about how do we actually help the residents have a sense of competency in motivational interviewing, and this isn't that, but it is a like welcome to motivational interviewing. You can at least embrace the spirit of it, and that'll get you somewhere, right?
I think you did a great job. I think the presentation went wonderful, and I think the you know, the teams just really love any extra. You could talk about motivational interviewing, you know, and we'll all take something from that lecture, what we need, right? I could hear it over and over. I could read the same book a couple times and, you know, just take the skills that I need of where I am in my development. So I think you did a great job.
Thank you.
One thing that we do that we often get a lot of really good feedback, and maybe it's something to think about for our next